and it has a role in certain areas. So the first thing that's important when you're trying to eliminate a disease is understand specifically hepatitis C is part of its endemic. So very tied to the substance use disorder epidemic, but also interacts with HIV, syphilis, STIs, etc. Why? Because when you define a endemic, it's the clustering of two or more conditions in a specific population. And when they cluster, these epidemics synergize and the outcomes are bad. Worse, meaning if you have Hep C, HIV, and SUD, the outcomes of all three epidemics are going to be worse than if you only had one epidemic. And interestingly, they are all started in very similar fashion. You have to have structural, social, and behavioral factors or conditions in place. And this is what ignites the epidemics and fuels them and maintains them going. So structural factors, the best example, lack of syringe service programs in an area. If you don't have clean needles and syringes, you're bound to have outbreaks of hepatitis B, C, HIV, because all these are bloodborne infections. And if you have social factors like stigma being the main one, but also other ones that are very important, like lack of employment, et cetera, you have people who are not accessing the health system when they should or when they can, and that's not good. And then you have the behavioral ones, in which shared beliefs is probably the most important one. In hepatitis C, well, first, many people that are at high risk don't even know they are at high risk. Some people have wrong beliefs of how you acquire it, and many patients don't even know you can cure it. So to straighten those things out is important. So when these factors are in place, you have these epidemics that start and they collide, substance use disorders, HIV, hepatitis C, STIs, and then COVID did not really help with all this problem because basically it prevented many people from accessing healthcare due to other non-COVID reasons, and that made things worse. So where are we right now with hepatitis C? Not very well overall in the United States. If you see this is published by the viral division of hepatitis at the CDC. Bless their hearts, what's ever left of them right now. But initial infection means you're RNA positive. And so if you're RNA positive, you should get treated. And the fourth column is you actually got treated, or a few cases, few percentage cleared the virus. So there's a big gap there. And you can see that only 23% of people who were on Medicaid got treated, 28% on Medicare, and 35% on private. So private people who are privately insured do a little bit better, but still everybody's doing bad because 65% of people with private insurance and hepatitis C do not get treated. So when you're trying to eliminate hepatitis C, there's two main goals. One is to reduce mortality. And I think we've done a fairly good job in the US about that because many of the baby boomers have been treated. And basically you need to treat the patients who have a long living hepatitis C infection that gives you time to develop cirrhosis and its complications. So if I get Hep C today, I'm not going to die of hepatitis C in the next 15 years. I'll probably die of a substance use disorder or something else, but not of hepatitis C. But once you've had hepatitis C for 15, 20 years, then you're at risk of cirrhosis and its complications. And as I mentioned, I think we did a better job at treating the baby boomers than at treating the young people. Now, to prevent new infections, you need to treat the people who are injecting drugs. And that's the tough part. Why? Because many of these patients do not go to your office, and they will hit the emergency departments. They will go to syringe service programs. They will certainly be in jail for a long time, and I'm sorry, for a short time, but for many periods of short times. And they will be on the streets and etc. So they usually do not get into your office, but if you see one, please jump on and treat them. This is just the natural evolution of hepatitis C. You can see you get infected, you have a normal liver, then most patients develop chronic hepatitis, and then about 20 to 40% actually develop cirrhosis. And once you have cirrhosis, then you're on the path of liver cancer and end-stage liver disease. It usually takes about 10 years to occur. That's why it's so important to detect people in this phase because you can cure them and they will not get cirrhosis from hepatitis C. Now, some patients do worse. Those who are males, are older, are drinking alcohol excessively, or have other liver conditions, either viral or non, like NASH, etc., they may develop cirrhosis much faster than that 20-year mark I told you. They may get cirrhosis within 5 or 10 years. So how do we diagnose hepatitis C? I think you're familiar with antibody testing, and you have point-of-care antibody testing, and you have laboratory-based antibody testing. And here are the turnaround times. So if you have a point-of-care, an OraSure, it's about 30 minutes. If you have to send it to a lab, it depends where your lab is, but let's say about a day. But then when you have to reflex that to an RNA to confirm the infection, it's about 1 to 4 days. Now, we have a new kid in the block called the hepatitis C quantitative. I'm sorry, it's qualitative. That's not right here. That's a typo. Qualitative point-of-care RNA, which in 45 minutes, you get a result. So let's say someone's walking in your office and you have this machine, which is not that expensive, and it's CLIA waived, and you test someone and they have a positive RNA, then bingo, you can treat them. You're ready to go. You don't have to send out an RNA and send a bunch of other labs and treat them later. And I'll walk you through this process. Here at Cherokee Nation, we started a program to reach out to the community, and we started with a harm reduction site. And well, that's our mobile unit, and this is just a layout of all the documents. We live in the US. You have to fill 150,000 forms to get anything done, but it is what it is. And then you have all the tests that we're using that I'll go over them. So we are approaching this as a syndemic. So we're testing people we're offering tests for hepatitis C, for HIV, and for syphilis. And here you see, you probably are familiar with this process. This is just a finger stick to do a point of care HIV, syphilis, or hep C test, antibody test. So you get a little drop of blood, you set it up in the kit. This one here is a hep C test. And the ChemBio does does HIV and syphilis. So in about 20 minutes overall, you have a reading of if the patient has a positive antibody for hep C or HIV or syphilis, and then you have to, if they're positive, depending on the clinical situation, is what you will do next. Now, the point of care RNA requires more blood. So you have to milk that finger a little, bleed that finger a little bit longer. You need 250 microliters of blood. Then you pipette it. So you poke the finger and you bleed it into this tube, and you pipette that blood out and you put it into this cartridge. And then you put the cartridge in the machine, which is a Gene Expert. And now you may have these machines. So these are the same ones that we use for COVID, RSV, influenza. And you have to check in if your site has one of these machines, because then you don't have to buy the machine. You just have to buy the kits. And you plug it in, and in 45 minutes, it'll tell you if the patient has hepatitis C RNA or not. Now, there is a learning curve. This is not as simple as point of care hep C antibodies or HIV. And especially when you're doing this in a harm reduction site in which patients come in dehydrated, they have calluses in their hands. We learned a lot of things, like do not use the hand which they hold their pipes when they're smoking. There's different preferences on which finger to poke. Nobody likes the thumb or the index finger, but all the other three are game. So we started hydrating the patients better. We used hand warmers to cause vasodilatation in the hand, and we used deeper lancets. And with that, we were successful in really improving our sample collection to be tested. And why is this? There's 3 columns here. The blue column is that we tested a patient for a point of care RNA. The black column is that the test failed, it was invalid. Why? Usually because there's not enough blood, or because when you're pipetting here, you're not filling the blood and the pipette smoothly. You have bubbles in the middle, and that machine just doesn't like that. But as we moved on and we learned all these, and the reds are positive patients, as we moved on, you can see that the black columns start dropping. And at the end, we have almost 100% valid tests. But there is a learning curve. I'm just mentioning this because if you do start using this technology, don't be first, reach out to us because we went through all the painful stuff. We learned how to use it, and we can give you some tips. But be prepared that it'll not be as easy as the point of care, but once you get it going, it's fine. So on the left, you'll see a cascade of care of patients that we did on the harm reduction side. So we had 49 that were, we were doing both antibody and RNA. 49 were antibody positive. This is before we started our point of care RNA. And then only 38% actually went to the clinic to get an RNA done. So you lose a lot of patients. You lose like 60, 70% of the patients because they don't go to the clinic to get their RNA done. On the contrary, when they're coming into the clinic, this is before and after we started doing point of care RNA. Before it was about 50%. Now it's 100%. But in the middle is 76% get an RNA done. And of those, all the ones, the 8 that were positive, all 8 got treated. Why? Because we started treatment on the same day. So that is I think that going forward is do point of care RNA if you can, or if you already have that RNA of the patient, when they come into the clinic, start treatment the same day. So this is what's coming up and the new guidelines from AASLD, and which is they start with a point of care test. Now, if you're not doing point of care and you have an RNA, it's the same. I mean, you use that RNA, positive RNA. So you do, if you have a positive RNA, as long as the patient has not been treated for Hep C before, as long as they do not have a history of hepatitis B or liver cancer or liver transplant or decompensated cirrhosis, you can start them on treatment. So if all this is no, you just do your medication reconciliation, draw blood, because you will need the hepatitis B serology, but the AASLD is not requiring that to initiate treatment. Just draw the blood, send the serology out. When the Hep B comes back, then you decide if you need to do anything different. 98% of the patients will not have chronic hepatitis B. And then you choose which treatment you want to use, either glecaprevir, preventosvir, which is Mavorite, or sofosbuvir, velpatasvir, which is Epclusa, and you just treat the patient. Follow-up, if you're the treater and you're the primary care, it's going to be with you. Here's not specified because we're planning to use this like on a harm reduction site or an ED, in which they will do this, but they will not be following up the patient. It'll be a different team. So it's 4 easy steps: HCV RNA, pre-treatment assessment, and I'll go over that in a minute. Check FIB4, but this is not, the most important thing is assess for cirrhosis, and that could be a clinical assessment. If you can do a FIB4 because you have a CBC done, fine, but you don't really have, you have to assess for cirrhosis, and actually for decompensated cirrhosis. That's what you need to assess for. And then you write the prescription, start treatment. So the major changes are use point of care RNA, hepatitis B virus status can be deferred. I mean, you draw the blood, wait for the results, and then act upon them. And now you don't have to do SVR12 anymore. It's SVR4. So 4 weeks after you finish treatment, you can do a RNA and confirm that the patient has been cured. Any questions on that? No? All right. So let's go to evaluating for cirrhosis. And I know you guys are knowledgeable on this, but we'll just review some things in case you want to change the way you're doing it. So the easiest way is FIB4. You need a platelet count. You need AST, ALT. You plug it into the formula, and it'll tell you if the patient may have cirrhosis or not. If you have a FibroScan, that's great, but not everybody does in their clinic, and that's just an expensive machine. The difference between a FIB4 and a transient elastography, it's the same as a Volkswagen, a little Volkswagen, and a BMW, but they both get you from A to B. You'll just go more comfy on one direction, but they'll do the same trick. And I've had a little Volkswagen, that's why I can say that. Then FibroSure, it's a commercial test. You draw blood, send it out, and it'll let you know what the fibrosis stage is. And then clinical evidence of cirrhosis. And that's what you can do to start treatment if you don't have any labs that day except for that RNA. So if the patient does not have edema or ascites on your clinical exam, and especially if they're young, like they haven't had time to develop cirrhosis, you can use your clinical judgment and say, okay, I'm going to start this patient. Even if they end up having cirrhosis, it's not going to change your treatment a lot or at all. But if they're decompensated, it will. So just basically ask them, did you ever have a GI bleed? Were you ever encephalopathic? Did you ever have ascites? And the answer is no to everything, and their physical exam does not reveal anything that is unusual, then you're good to go. If you only have a CBC, if you have more than 150,000 platelets, you're not cirrhotic. So you can use platelets by itself also. Then you do your medication reconciliation, and I'll go over this in the next few slides. So this is just a reminder of so we stage fibrosis of the liver, not so much because of treatment, because even until you get to patients with cirrhosis, treatment is the same, but it's for follow-up. Because if someone has cirrhosis, they will need liver cancer surveillance every 6 months. They will need an EGD. So the clinical follow-up is different. So here on A, you see no fibrosis. These blue is fibrosis. Red is not fibrosis. Now, you do have some blue here because the walls of the veins have fibrous a mesh. So that's why you're seeing them blue around the vein, around the central lobular vein and the portal vein and central lobular vein. But everything else is pink. When you get to B, that's diffuse periportal fibrosis. You can see a lot of blue staining around the veins. When you get to C, you see bridging fibrosis. You see these bridges of fibrosis that go from the portal vein to the central lobular vein. This is a liver biopsy. And when you get to D, then you see those nodules, pieces of liver engulfed by fibrosis, and that's cirrhosis. Now, decompensated cirrhosis is the clinical. It's not a biopsy diagnosis. It's a patient has ascites, or they have a bleed from esophageal varices, are they encephalopathic, or are they jaundice? All this is clinical and question, history and clinical. So you can define if the patient has no chance of having decompensated cirrhosis and low chance of having cirrhosis. So this is just a FIB4 index that you're familiar with. You just plug in the numbers, age, AST, ALT, and platelets. And if the number is less than 3.25, then the patient does not have advanced liver fibrosis. If it's greater than 3.25, they do. And this is a fibro test, it's just a blood draw, send it out, and it'll come back with the results of the fibrosis score. But for this, you have to wait days or weeks. This is transient elastography. It's just a technique in which you do a shear wave through the liver, which is a thump. It's a mechanical triggered wave, and then you measure the speed of that wave with ultrasound technology. And if the wave goes very fast, that means that the liver is very scarred, and that gives you a number, and that number correlates with the different stages of cirrhosis. So if it's less than 7, you're good. If it's less than 12.5, that's cirrhosis. And in between is F1, F2, and F3. And finally, it's clinical, and that's what I think we can use, and platelet count if you have a CBC handy. Now, it doesn't have to be a CBC of that day, for that matter, not even for the FIB4. It has to be within the last 6 months. Many of our patients have been to the ER or somewhere, and you have some labs, and you can calculate this. It doesn't have to be fresh of that day. Ultrasounds are great to confirm cirrhosis, but they're bad to rule out cirrhosis. 40% of patients with cirrhosis have normal ultrasounds. So it's not a great test for detecting cirrhosis. Okay, so you saw your patient, you did a clinical exam, you asked them, they're not yellow, you don't find ascites, they don't have edema. You ask them about GI bleeds, they say no, never been very confused except when they voted on the last election. And other than that, they look fine. And so you're ready to treat. You got a point of care RNA, or you had an RNA already in the system that, that's why the patient's there. So you choose either Mavorite or Epclusa, And that'll depend on many factors, which one you choose. It'll depend on the insurance coverage, how do you get the meds? That's the main driver usually. Also on drug-drug interactions, and also on, if you get to that point, patient preference. If they want to take one pill, once a day for 12 weeks, or 3 pills once a day with food for 8 weeks. And the beauty of the simplified algorithm is that you don't need to monitor these patients until they're done. So you give them the treatment, they go home, and you don't have to see them again until they come back 4 weeks after they finish treatment. Now, I do want to mention that you don't have to see them, but I do encourage you to talk to them. I know we don't live in a talking society. It's all texting, but I would certainly, texting would be fine too if you know who you're texting. Make sure that you reach the patient that you want to reach, and make sure they're okay, that they're taking their meds, that they follow the instructions, see if they have any problems or issues. So keep in touch with them, but they don't have to physically come back into the clinic. This is the tool that I use for drug-drug interactions. There's many out there. This one's very simple. You can download it in your app, and it's called the Liverpool Hepatitis Hep Drug Interactions. Then you plug in the medications the patient has, plus the Hep C treatment you're going to use, and it'll tell you if you need to do something about those drugs. The most common interactions, as you will know, is depending on which Hep C drug you're using. Could be they're on a high-dose PPI, if it's a Epclusa, or a statin, in which they both interact with both drugs, but some statins are better than others, or seizure medications that are basically contraindicated, like carbamazepine or phenytoin or barbiturates. Those are contraindicated. But the app is great. It'll tell you what to do. And many of the interactions is just like, just keep an eye on it. That doesn't mean you can't treat the patient. Let's say they're using prazosin, and that can lower your blood pressure, measure the blood pressure just to make sure they're not going to get too low, and you need to change the dose of the other drug. And then, assessment is the same. You need to educate the patient what your goals are, what their goals are, and that they need to take their meds every day. And pre-treatment laboratory testing, as long as it's within 6 months, it's fine. But you will need a CBC, liver, LFTs, and you can, and hepatitis B serology, and an HIV, and then send them out. HIV, I want to mention, do a point of care HIV, make sure at least that's negative, because if they're HIV positive, I prefer that you treat the HIV first and then start with the Hep C. But that's a point of care that you could do in your clinic too. So this is the simplified algorithm by the AASLD, the one that you will find on the website. It's basically what I told you. Now, the simplified part of it is that there's no laboratory monitoring required. I mean, as long as the patients don't have cirrhosis, they can go home, come back 4 weeks after they finish their treatment, and you get the labs for a cure. And if your cure is achieved, great. If it's not achieved, well, you'll have to reevaluate that situation. But it's in the past, when we started doing this, you would get all the labs, wait for all the results, wait for the medication, start them on treatment. At 4 weeks, another labs. At 8 weeks, more labs. So it was kind of driving the patients crazy. Now, if a patient wants to come and see you, don't say no. That'll be another RVU notch for you, and the patient will be happy. But it means that you don't have to see him, meaning if it's a burden for the patient to go to the clinic, then that burden's away. It's out. And I think I will stop there, because I really wanted to highlight that you have point of care RNA, that now it says SVR4, not SVR12, and that you don't have to wait for all the results before you start treatment, as long as you clinically have decided that the patient does not have cirrhosis, or for sure decompensated cirrhosis. I don't know if there's any questions.
Thank you much. I know one thing is that we do have, depending where Feather River and Greenville Rancheria are, there are a lot of policies, standing orders, and templates that we can supply for you. I'll put my email in the chat. Dr. Mera also has office hours tomorrow. We can put you on that invite. Anything from just screening algorithms and follow up to kind of more of the intangibles like his outreach program and how that worked. I do have one question, but I'll wait. I think, Josh, you might have been coming off of mute there.
No, I was curious about the outreach program a little bit and more of the details of it. Our clinic currently, so in our largest clinic in Oroville, we can draw blood work in-house. And so then if we're needing to have labs, obviously we're not going to receive the results same day. But when the new point of care HCV, RNA testing came out, we didn't feel like it would be necessarily of great utility here. But then our Yuba City clinic, we don't have a lab draw station there. And that's been a pretty significant barrier for our patients. And we actually had a patient recently, it was funny, who I was seeing him in Yuba City for 3 years, and he never got his Hep C labs done. And then I saw him up here in Oroville, and it just happened to be when our lab was open. So then I just walked him over to the lab, drew the blood work, and he had active hepatitis C. Just he never would go to the lab to get his blood work drawn. And so it's funny, in cases like that, I could see how there would be this utility if you don't have that access to a lab, in clinic. And so I was just kind of curious of the setting that you guys were doing the point of care testing in, what resources were available there. And it's pretty interesting, like you said, that for the positives, that you just basically were able to have that conversation and get a prescription started for them.
Yeah, so those were people who had Medicaid, and we can get Medicaid prescriptions that same day. That's within an hour. If they had some other insurance, that would not have been possible because we have to order the meds. But anyways, so yeah, that's a great question. I think that the point of care RNA is useful in circumstances that you're ready to start treatment. Like you have medications on site, or you can get them that same day. That's the best case scenario. And where are those sites? Like if you're, for example, in the emergency room, if you're willing to do the whole shebang, and that's the problem, not everybody is. Or if you are in a jail, because that's where we're trying to get into, is to try to see if we can do it in jails, because patients in jails are not like in prison, they're there for a year or more. In jails, they may be there for 3 or 4 days or less. But if we can get them to a point of care RNA and then start treatment there, that would be great. But even if you can't, and that's the second tier where this test is useful, at least you're telling the patient, you are HCV RNA positive, you have active hepatitis C, you need treatment. Very different than when you say, oh, you have an antibody positive, you have to come to the clinic for a confirmation test. And people try to deny those confirmations. They hope for the best. Oh, maybe it's a false positive, or maybe I don't have it. But when you're telling them you do have it, we've seen more patients from, like, when we didn't have the point of care RNA, we've seen more patients. When we didn't have it, very few patients went to the clinic from the harm reduction side. Very few, less than 10%. When we started doing the point of care RNA, that we still unfortunately couldn't treat them on site because it's a whole different world of bureaucracy. But we had like 50% coming to the clinic of those, because they knew they were active. They understood they needed treatment. But and those who would come into the clinic to get tested, and we did a point of care, instead of going to harm reduction, they're injecting drugs, but they decided to come to the clinic. All of them got started. I mean, that's old, not old. I mean, some months old data, but we have fresher data, and everybody that is willing to get treated on the same day, as long as you give them meds. So you'll get more patients treated. I think that's the way the US has to go. The other side is in the hospital. If you don't have an RNA in-house, it takes 3 or 4 days to get a result back. So you may have a patient who's got admitted, let's say, for a cellulitis due to injection drug use of their arm. So they're injecting, do the point of care RNA. If it's positive, that patient needs treatment, and maybe you're able to get it in the hospital. It'll depend on each place that you are, right? I cannot make a blanket recommendation. You have to analyze what can you do where you are. The other, which I think is potentially very useful, like what you were saying on that clinic, that you don't have a lab, And I know maybe you don't have a phlebotomist to go there either, but what we're planning to do on the harm reduction side is send a phlebotomist there. And so they'll do the point of care. And people who are doing, for example, they come back positive for syphilis, the phlebotomist can draw the RPR. Now, the lab is not there. She just draws the lab, the blood and the tubes, and then she carries it back to the clinic where the lab is, and they process those tubes there. So that's fine. You have to see what can you do where you are. What is the maximum capacity of what you have? And see if that point of care will be of utility or not. Now, the other thing is, it may be a lesser cost on the long run, because the point of, if you have the machine, and you may have it, well, if you don't have the machine, costs $25,000. But if you have the machine, it's $35 a pop, the RNA. When you're sending out an RNA, it's much more expensive than that in general. It's from $70, $90 to $300. So if you have that point of care RNA, let's say you're doing point of care antibody testing, someone's positive, you do the RNA right then, and if it's negative, it's not as sensitive as the send out RNA, but it's 99% sensitive. So you'll miss very, very few. And that way you can save not only money, but having to send labs out, et cetera. So knowing the cost, $36 a test, $25,000 for the machine if you don't have it. See if that would improve the care in your site in some way or form. And then you come to the decision if you'll do it or not. But for example, can you get meds on the same day for some of the patients?
We cannot.
Okay.
Yeah, that would be a
barrier on the same day. I think the only benefit of the point of care RNA would be to tell the patient you are actively infected. You should, let's say if they're injecting drugs, make sure they go to a syringe service program and get clean needles and syringes so they don't share anymore. That's the type of impact that you may have. And maybe they will be more committed to coming back and getting treated. Other than that, those are the benefits of that.
Thank you.
You're welcome. Great question.
Every state's a bit different, and California is my home state, so I generalize. I like to think it's pretty easy there. But as far as dealing with Medi-Cal, drug procurement, outreach policies, are there any other pain points that are that you're dealing with in either Greenville or in Feather River?
I was just curious with Josh, is the access to medication, is that because it's something that has to be ordered, or just because it's hard to get medication in your area? I mean, I know where Feather River is, or where Orville is, but is it?
No, it's just because the meds have to be ordered. Yeah.
Okay, that's what I wondered. Yeah, it's a specialty. Okay,
We don't fill them in-house.
sure.
We do have an in-house pharmacy, but they decided not to fill the Hep C meds in-house, and so then I have to order them. We can get them quickly though. It's not something that's too delayed. But that's pretty much it.
Gotcha. Okay. Of course, this is all, this is something we're just starting to do, and I would love to be able to do a syringe exchange program. I just don't know if we haven't put it up to our tribal council yet to see if that's something that they would let us work on. So I don't know where their mindset is on that, but that would be my next hurdle along with this to, implement, at least get started.
Carrie, if you want, I just helped Rosewood Sioux Tribe draft ordinance, and we've helped with like resolutions before to put before council, obviously like a conversation first, but if you need anything around that, yeah, we're happy to help with that.
Oh, perfect. Thank you.
Yeah, I think we have to wait because the country's in turmoil right now, and we don't know exactly where things are going. In the past there was this Hep C elimination plan for the US, et cetera. Sometimes one of the things that I do is, okay, maybe if it's not terribly complicated to get this today, like a point of care RNA, I may be ready when the time comes that you're ready to use it, broadly. Because when that time comes, then you're going to run into the problem that there's not going to be enough machines and kits around because everybody wants one, right? Like if, let's say the United States declared a Hep C elimination program tomorrow, and they're giving billions of dollars like they did to the VA to fund this, then suddenly you would have all these resources that you could use. The barriers are going to be different. Is getting those resources because everybody wants one. So maybe one thing you could do is check what are you doing for influenza, RSV, and COVID testing, because these machines do that. And actually, we had 4 at Cherokee Nation because we were using them for during the pandemic. Many IHS sites got those machines. So if you have the machine, that's one expense you don't have to worry about, and then just the rest is just buying kits, which is not more expensive than when you're spending on your lab.
I had one last question, then I'll put information on the office hours and our evaluation in the chat and my email. So any follow-ups that we mentioned, you can follow up. But I've heard it generalized in one meta-analysis that if you have all of your Hep C patients, about a third are probably pretty motivated and easy to reach, let's say, for lack of a better term. A third maybe have barriers getting to care, and a third are just, let's say, not ready. Or are not able to engage. I don't know if you found that, Josh, in that holds up, and if you have any words of wisdom on like how you've engaged that second third, right? That you can maybe engage. I did see in California, my brief visits, there's considerable social services and non-clinical support on some medical teams in some facilities, and are you able to use those sort of backgrounds to help you link patients to care?
Yeah. I mean, so you'd asked earlier, where are the bottlenecks, or what challenges do we have, right? Right now, speaking for our cohort, we have an initiative in place for screening. So we're trying to continue just to keep Hep C on the forefront when we do community outreach and things. But otherwise, we have 2 patients that we have not been able to treat in the time that I've been here. And in both cases, they're just unfortunately in the middle of substance use issues. So whether it's alcohol or meth, both of which are big problems out here. And just unfortunately, those folks are just so lost in all of that it's been really challenging to get them going on treatment and to follow up with them. But that's pretty much it. The rest of the barriers to care we've been able to navigate. And I think a lot of it has to do with what Dr. Mera highlighted in his talk, just kind of, I think, creative solutions, even with what you were just mentioning, Dr. Mera, point of care testing, how to utilize it in the hospital, things like that. Those 2 patients come to my mind because like maybe, if there was a way for us to test these patients more quickly and try to link them to treatment a little bit more quickly, like whether that's coordinating with our local emergency room or hospital, something like that. And maybe we can get them treated even while they're again kind of out there in the wind and hard to nail down. But the rest of the barriers we've been able to navigate. I recently treated a patient who we just did the whole process over the phone. He had a lot of barriers to coming in, but had come in one time as a walk-in because he was sick, and one of our providers had the forethought to grab some labs while he was here, and she was able to get enough that it was a basic evaluation for the Hep C. And like Dr. Mera was saying, you really don't need a lot as far as labs go anymore to really just get people going. And so when I spoke with him, he didn't want to come back in. He's 3 hours away and has a lot of transportation limitations. But then we just did the whole thing over the phone and it worked, and so I think a lot of it has to do with just providers being flexible and able to work with patients, sometimes coming up with creative solutions. But then again, we have that small cohort that we're still just trying to get them in and get them treated, but the substance use is really the big problem.
Yeah, the other thing I want to mention is sometimes you don't have to, don't make excellent the enemy of good, or good the enemy of excellent, because maybe you can't treat that day, But you have that point of care RNA, you can order the meds that day. You don't have to send that RNA out and wait for it to come back, and then I'll order the meds, so you will be saving some steps. So I think, our experience with that test, except for the initial, surprise, like it's not working. But once we got over that part, it's been great. I mean, we've been able to treat a lot of people that we're sure would never have gotten treated because we had them, that was a window of opportunity. Even the ones that we tested the harm reduction, like I said, they had to go to the clinic. We couldn't start them at the minute that the test was positive, but we still captured 50% of those. In the past, we wouldn't have captured any, 0. So I think that it does give you an improvement. The magnitude of the improvement depends on other factors that sometimes are out of our control.
Thank you.
There's also, I think in 1 year, good news for the future. Abbott and this other company are working with a point of care RNA for HIV, Hep C, and Hep B. So it's a one finger stick and you get all 3 viruses. I think it'll take a while for it to get, done and approved, but it'll be easier in the future to get all our tests in 1 day and same in 1 hour and get everything done. There's also Roche has an antigen for hepatitis C that they're trying to get FDA approval. And it's a pretty good test. The only thing, it's not point of care, so you have to have it in your lab. It is fast, though. It's 20-minute results, but the machine has to be in the lab. So, I think there's role for all these tests in different scenarios. We just have to find where they fit well in our work or in your work. All right. Well, it's been a pleasure being with you. I don't know if there's any other questions.
Thanks. No, we'll have, if anyone has anything to add, we can do, but Alicia, if you could add the, I think we have a survey link to put in the chat. If you guys could do it, I think there's 4 questions, 5 questions, and it helps us form syllabus for the future. You're already on the mailing list for the office hours for tomorrow that Jorge has. And if that schedule doesn't work for you, we can answer any other questions. We can just make it happen. I'll put in my email in the chat. And then I can hook you up with the answer as needed. So, and any of the things that were mentioned today. Okay, there's a link. Thanks, Alicia. All right, I'll give you 10 minutes back. I'm going to stay on. I'll leave the Zoom room open. Leah, I just noticed that you've joined late, so I know it's hard at the clinical schedule, but thanks for jumping in, and I hope this was useful.
Thank you.
Yeah, thank you very much.
All right, everyone. See you. Thanks.
I'm gonna pause the recording.